It is my pleasure to introduce you to our presenting faculty, Dr. Yamen Smadi, a friend and colleague from Arnold Palmer Children's Hospital in Orlando, Florida. He is a passionate interventional endoscopist, a medical innovator, and director of the Eosinophilic Esophagitis Center at the Center for Digestive Health and Nutrition at Arnold Palmer. As demonstrated by his recent publication on the introduction of sedation-free transnasal esophagogastroduodenoscopy, or EGD, his dedication to offering diagnostic options without anesthesia to his patients is unwavering. He piloted the introduction of this technology, navigated his health system, and now offers on a regular sedation-free endoscopic options to the patients of the southeastern United States. Dr. Smadi, we thank you for your presentation this evening and for sharing your expert knowledge about starting a new sedation-free program. Our participants, we hope that you enjoy learning from him as much as we have enjoyed working with him. Thank you so much for joining us this evening. And Dr. Smadi, I will turn it over to you.
Thank you so much, Joe. Thank you so much, everyone. It's an honor to present today. So today we're going to talk about very much our personal experience about bringing sedation-free transnasal endoscopy to our practice. I will try to cover these 5 points. Establishing sedation-free transnasal endoscopy. Why do you need to do that? And then how do you do it? We're going to talk about our personal experience, the good and the surprises, results of our experience so far, and some personal advice. I will try to make this more applicable to our clinical practice. This is a real case, nine-year-old male who continued to have abdominal pain and diarrhea following an acute gastroenteritis. Primary care physician ordered TTG, IgA, which was positive at a level of 70 with the upper limit of 15. Patient was referred to GI for celiac workup. Upon GI evaluation, he was still having some pain, some diarrhea. He's growing well with normal physical exam. Dad really wanted to know if this is celiac disease, but he doesn't like the idea of endoscopy under sedation. So what options do we have to offer for such a case? The revolution of transnasal endoscopy went through many stages. I think probably the early milestones in the 1994 when our colleagues from ENT published their data about transnasal endoscopy. And very little happened till 2015 when our colleagues in Colorado started using this technique clinically for eosinophilic esophagitis and the aerodigestive clinic. And in 2022, when EvoEndo was approved by FDA to be used for transnasal endoscopy. So the first question is about why. Why do you need to bring sedation-free transnasal endoscopy to your practice? Because of 3 main pillars. It's safer, more convenient, and improves access. Transnasal endoscopy is definitely safer because it eliminates the risk of anesthesia and the use of anesthesia drugs. It's more convenience for the family. There's no IV. Time in facility is shorter. Time for the procedure is shorter. And patients can go back to their school or activities right after the endoscopy versus if they go for sedation EGD, then they have to recover for the rest of the day with no driving, dancing, swimming restrictions. And finally, it improves access. When you take these cases out of the OR, out of the sedation endoscopy suite, you free that suite or the OR for cases which requires sedation. You improves access for families. You offer now more places to do endoscopy in general. And eventually, it improves the access by bringing the cost down. So we justified why do you need to bring sedation-free endoscopy? Why do you need to use the EvoEndo system or the single-use only approved FDA system for transnasal endoscopy? Number one, it's ultra slim. You are talking about 3 millimeter versus about 6 millimeter. This is very important when you're going in the nose awake. It has a channel which is 2.0 millimeter, allows you to take biopsies and to use the tools which can fit in that channel. It has air, suction, water capabilities. The scope moves in 4 directions. It's long enough to allow full endoscopy, reaching the duodenum and taking biopsies from the duodenum for different purposes, including celiac disease evaluation, disaccharidase evaluation, small intestinal bacterial overgrowth. You reduce the startup cost. There isn't a big sum of money you have to pay upfront, like when we buy our reusable scopes. And it eliminates the fees of processing the scope, cleaning the scope, and repairing the scope. This is a hidden fee which we learned after we started using a transnasal endoscopy. If you use other reusable scopes for transnasal endoscopy, there is about $300 every time you use the scope to clean it, process it, and because they break all the time. And finally, this is the only FDA approved for transnasal endoscopy. So when you use other reusable scopes for TNE, if you use the bronchoscopes or the laryngoscopes, they are FDA approved to be used for the lungs or the larynx. They're not approved to be to use for EGD. To follow up on the case which we presented, this patient was interested in sedation-free transnasal endoscopy. We did that through the nose. We did full endoscopy. Grossly, his duodenum appeared normal. We were able to take 6 biopsies, 4 from the duodenum, 2 from the bulb. The biopsies were normal. We also did 1 biopsy for disaccharidase assay, and that was also normal. The normal biopsy, normal disaccharidase, normal appearance was against the diagnosis of celiac disease. Total time for the family in facility was about 60 minutes. Total time to finish a full EGD through the nose was 25 minutes. Patient tolerated the procedure very well and went back to school right after the endoscopy. Few months after, repeated celiac disease antibodies were normal. So most likely that elevation was falsely positive for some reason. Dad was very appreciative of not exposing his son to anesthesia. I brought this example just to show you how nice it is to have sedation-free endoscopy. We solved the case without needing to put the kid under anesthesia. And that is the unique thing about sedation-free endoscopy. You can answer all these questions more accurately. Does he have celiac disease or no? It took 25 minutes, no sedation, went back to school right after. Dad actually works for our organization. He just took 2 hours break and went back to work. So way more safer, way more convenient, and improved the access definitely. So we talked about the why. Now how do you build sedation-free transnasal endoscopy? I think there are 4 elements to do that. You need the right patients, you need the right equipments, you need the right staff, and you need to have the right training. So these are all the indications for transnasal endoscopy or sedation-free endoscopy. As you see, this was put together by the EvoEndo team, and it very much covered the indications based on the organ you are targeting, whether it's the esophagus or the stomach or the duodenum. We're all very familiar with EOE being the most common diagnosis for TNE EGD. But as you see, you can do this for follow-up erosive esophagitis, follow-up candida esophagitis, dysphagia in general after resolution of inflammation, H. pylori culture, celiac disease like the case we presented, disaccharidase assays, and other indications. In general, what we found, we do TNE or sedation-free endoscopy in 2 cases. One, when we can do sedated EGD, a patient who has cardiac issue prevents him or making the anesthesia very risky. Patient with muscular dystrophy, where if they go to sleep, it's a very big deal. Patients with pulmonary hypertension who doesn't tolerate anesthesia well. So we have done cases where the main reason to do sedation-free endoscopy was because they are not good candidate for sedated EGD. And the second case is when it's preferred to do sedation-free TNE, patients who require multiple endoscopies like EOE, patients who we have very simple answer. Does he need to be on PPI twice a day or 1 a day? Can we decrease the dose of inhaled steroids to half and see if he stays in remission? So sorry. Can we introduce baked dairy into his diet? Does that flare his EOE? Such tiny, small questions, it would be very nice to answer them using a sedation-free endoscopy. First, patient selection consideration. You have, EOE clinics usually are the most in need to use TNE, but remember, when you're starting up the program, you want to guarantee success. So choose patients who are a little bit older, who had experience taking some nasal medications, even if it's a Flonase, who do well with the procedures and generally IVs and shots for vaccinations. And if they had the previous experience of a 24-hour impedance probe or an NG tube, then they are a great candidate. Our first patient who underwent the transnasal endoscopy in our center was someone who had the esophageal brushing, which is similar to esophageal string or esophageal sponge. He had that multiple times and tolerated that very well. Don't choose someone who is very young, who is known to have anxiety, who freaks out even with sedated in EGD. Choose your patients carefully for the first maybe 2-3 sessions. Then you can do more cases where they are younger, where they, you can risk that the procedure might not go well. But overall, keep in mind that the success rate for transnasal endoscopy across the board is about 94 to 98%. This is what has been published already, and this is our personal experience as well. Equipment, you need a room. This room doesn't need to be as fancy as an OR room or an endoscopy room. When we started doing our cases, we did them in a clinic room. You do need the controller, which is equivalent of the processor for the reusable scopes. You need air or CO2. And if you don't have that in the room, you can have a tank for CO2. There is a way to add an adapter to the EvoEndo system where you use the Olympus CO2 source. You need some suctioning mechanisms either in the wall if you are in a hospital or an endosuite, or you can buy a suctioning machine. And again, when we started doing these, we did them in the clinic, completely in an office-based room, which did not have air or CO2, did not have suctioning. We bought a tank for CO2 and we bought a suction machine. You need a monitor which can be connected to the EvoEndo system, and you need a computer to write your report and to save the pictures. Endoscopy supplies, you need biopsy forceps which can fit in a 2mm channel. You need some containers, medical lubricants, some water bottles like any regular endoscopy. Distraction and dissociation supply, it's very important when you start that, I think, to definitely focus on distracting the patient. The VR system is very good in keeping the kids distracted and dissociated from their environment. This has been shown in literature, and this has been our experience as well. When we started, we just did VR ourselves. And then we included, we included child life in our team, and we found that they are of great value. You need medication, lidocaine of some form. I prefer to have lidocaine liquid to use as a spray, and lidocaine gel to use at the tip of the nose to numb the tip of the nose and to lubricate that area. You need some anti-congestion like Afrin or so, and you need an atomizer to try and change the liquid form of the lidocaine into a spray. This is again is a proposal by the EvoEndo team, is to have very much a 2 of each position: endoscopy, 1 nurse, 1 child life and medical assistant, and to have 2 teams very much so they can cover each other. When you start, it's probably might not be doable to have 2 for each position. So when we started, it was 1 endoscopy, 1 nurse, 1 MA. We didn't have even child life. But if you can start with a team of 4, nurse, endoscopist, of course, MA, or endotech, and a child life, then the program starts up stronger and your chance of successful is higher. This is a proposed process of how does this go. So you introduce the idea of transnasal endoscopy to your team in the hospital. Then you have on-site installation and training by EvoEndo team. Then you start practicing on the demo, and you can see in the right side of the slide, practicing on the demo is very important. You are doing these cases on live patients, so it's very important to feel confident and to know what to expect before you start on live patients. You practice on the demo as much as you can. Then you choose your first case carefully and you do that. And that takes about 4 weeks from the time of installation. And then you keep practicing on the demo and bringing more cases. You can start with just intubating the esophagus and doing esophagoscopy or esophagogastroscopy, and then you can advance and do full EGD using transnasal endoscopy. Our personal experience, we built the business plan and introduced this to our team. They approved us for a pilot study of 10 patients. We did that in the office, as I said. So our first patients were done in an office base, and that's what we published in the paper I'm going to share with you in a few slides. And then we looked at the outcome of the first 10 patients. After that, our administration took a decision to expand the pilot. So they did not give us green light after our first 10 cases. They wanted us to do another 10 cases. We did another 10 cases, but this time at the endo suite in a sedation-free endoscopy suite. And after that, we got approval and the program became official. These are startup considerations. You have to meet with your business team to develop the program structures. They are very essential. If the program fails from a business standpoint, even if it's great clinically, you can't maintain that. So you have to have your business team on your side. Reach out to EvoEndo team. They are a great resource. They are extremely helpful. And they have been through these stages with at least 25 hospitals before your hospital. Build the clinical TNE team as a nurse who's interested, an MA or an endotech, child life. Develop the process for TNE, where do referrals come from, ordering, prioritization, scheduling, prepare patients and information material, prepare the room and the equipment. A check with bioengineering, be sure that you have the hardware and the software is applicable. And finally, start the training for TNE. And as we said, the training is probably on 2 different stages: scoping to the stomach, scoping the stomach, and then doing full EGD. These are frequent questions might come up during your initial meeting with your business team and division administration. So they would always ask you, will unsedated transnasal endoscopy impact our sedated procedure volume? You do cases in the OR or in the endoscopy suite. Now you are taking some of these cases out to do them sedation-free. So would that affect the volume in the OR or in the sedated endoscopy suite? And our experience and everyone's experience has been it doesn't. We all are experiencing a lag of doing procedure in the OR or in the sedated suites. If you try to schedule an endoscopy on most places, it's at least a few weeks before you have an opening. We are limited with anesthesia, with OR nurses. So you are freeing these rooms and taking some of the pressure and the load off these very busy places and offering to do them without sedation. That's number one. Number two, remember that because it's sedation-free, you can answer clinical questions more accurately. You probably might not offer sedated EGD to answer a question whether you can decrease the dose of PPI from 40 once a day to 20 once a day. That seems like a very big price for this important information. But if it is sedation-free, you and the patient feels more comfortable to move on. You might not offer sedated EGD to answer a question. We know that dairy is a trigger, but what about baked dairy or cooked dairy? But when it's sedation-free, you might offer, you and the family will feel more comfortable to offer that to answer such questions. The other question comes up with meeting your leader team is, can unsedated TNE increase the revenue for the pediatric GI division? I believe so, and this has been the experience of everyone who had TNE centers. Definitely you are creating a new procedure and it's unique procedure. You will retain patients who will need TNE in your practice, and you might also get referrals from outside territories. How can unsedated TNE be used to increase endoscopy volume and hospital revenue? Again, the argument is If we had 10 patients undergoing sedated EGD, now that we are offering sedated EGD and sedation-free TNE, we might be doing 15 a month instead of 10 a month. It's not that we're going to do 5 here and 5 there. Does unsedated TNE have CPT codes available? Of course, and we're going to show you a specific slide about that. And the last thing, this always comes up. Why should we use single-use system or EvoEndo system versus the reusable scopes, the reusable bronchoscopes or laryngoscopes? We already have those. We don't need to invest in bringing a new system just to do TNE. So number one, remember that EvoEndo is the only FDA approved to do transnasal endoscopy. When you use the other reusable scopes, they are not FDA approved for that purpose. Number two, the EvoEndo is way more slimmer, so it's thin compared to the other scopes, but thin, and at the same time allows you to take biopsies with the 2.0 millimeter channel. So convenience and comfort level is much higher with EvoEndo. It's much easier to do EvoEndo TNE than to use the reusable scopes. And as I said, it allows you to do full EGD if needed. Plus, as we mentioned, no startup cost. You're going to save money on reprocessing and repairing scopes and all the reasons. So our personal experience, the good, we had great patient satisfaction after we started the program. Everyone who underwent transnasal endoscopy was extremely happy. And again, this is our personal experience, but every center who underwent building a transnasal endoscopy very much shared the same results. Improved access. Now, we at one point we had waiting time for more than 5 to 6 weeks to do an endoscopy, but because we took some of the load out of the OR and the sedated suites, now we can offer endoscopy sooner and more efficient. Successful reimbursement. We'll talk more about our experience with that. Press and the news. There is a momentum for sedation-free endoscopy, specifically in children. The risk of anesthesia is on the rise, and we were interviewed by local TV channels twice in 1 week. That was very important for our center, for our hospital, for our patients. So this something might give you advantage over other centers, might lift you and your team up. And finally, as I said, increased out of territory referrals. Yes, we retained our own patients who needs to have TNE instead of sending them out, but also we gained referrals from areas which probably they would not have come to us just for sedated EGD. This is a proposed a schedule of how the flow should go once you build the unit. So patient to check in, they consent, then they have the procedure, then they go home. Again, the recovery from this is about 5 to 10 minutes, and then you clean up the room and you bring another patient. When we started, we had 1 hour slots for every TNE, and we shortened it to about 40 minutes now. So I think that's reasonable. When you start, probably offer a 1 hour slot, but definitely you can decrease that with time. I was actually impressed that it was our endoscopy team who said, you know what, 1 hour is too long. We are really finishing, on average within 30 minutes. So let's bring the intervals down to 40 minutes, which was very good. Now, our personal experience, these surprises. As I told you, we started with office-based sedation-free transnasal endoscopy. Clinically, our experience was awesome. We were able to do the procedure. The families were happy. We were happy. No complications. Everything went well clinically. But I do have, I was surprised when we started doing this. We started doing very much full EGD whenever we were able to. And when we did full EG transnasally, we tried to bill for full EGD. And then, it wasn't a surprise for us, but when we billed for the experimental codes, which are the 3 codes on the bottom of the screen, we had issues with reimbursement. And then that very much placed the whole program at risk. Most likely your administration will tell you, okay, we'll give you a pilot for 10, 20 cases to do. And if the reimbursement is not good based on the first 10 cases, then they might say, this is not we can't make this survive. This might not work. So it's very important, in our opinion, that when you start with guaranteed established codes. And these are the codes which I refer to with the red arrow, 43197, 43198. That's transnasal endoscopy with or without biopsy. And that is when you go through the nose to the esophagus to the stomach, and the main purpose of this is to evaluate the esophagus. So once we started using the more established codes, everything went well, and we were able to be reimbursed for these procedures. But as I said, it is important to, when you start, guarantee success. And so start with way more established ways. Start an endoscopy suite. Start with the established codes, and then when you grow, you can go to do more risky things, which if failed later, then you are strong, the program is up and running. We were very surprised by how soon these slots are filling, and we are also very impressed that this most likely will be a measure for the US news. We so far has finished 50 successful transnasal endoscopy. 12 of them are full EGD, and the program is growing and expanding. And again, this is not our only personal experience. All over the programs, when they started this, they expect about 400% growth over 4 years. We published our initial trials of transnasal EGD in the office, and when we intended to do full EGD in the office, sedation-free, using the EvoEndo system, when we intended to do that in 8 patients, we were successful to finish completely in 7 patients. So this is very doable, and again, EvoEndo is a real revolution in the transnasal endoscopy. It allows to do full EGD awake whenever it's needed. A few tips. I do encourage you to review the webinars presented in this webinar series before. There was a great one about business planning by Dr. Sfera from Rainbow, a great one about clinical support staff by Clint and his colleagues from nurses from Wisconsin and Colorado, a great one by Dr. Wen about choosing the correct patient. I added 2 more tips, which are our personal experience. When you start doing this, probably it is better to start in an endoscopy suite and then bring it back to an office-based if doable. That's what our personal experience has been. We started in an office, a non-procedure place, and it worked very well, but the reimbursement was a struggle. Then we moved to endoscopy suite. And we are thriving very well there. My hope is to bring it back to the office at one point, but after the program is really up and running, and I have good support from our billing department. Billing, again, when you start, probably it's better to start with established codes, and then after you are up and running, you can use the new experimental codes, which if you succeed in the reimbursement, they do reimburse higher than the established codes. And that concludes the presentation. Thank you so much for allowing me to present. I think we have time for questions now.
And thank you so much, Dr. Smadi, for that wonderful presentation. And we already have some questions already popping in. Officially, we're now going to begin our question and answer session. I also want to remind everyone and all our participants, if you are interested in a product demonstration, please click on the link in the chat, or if rather, please message EvoEndo Marketing via the Zoom chat as well too, in a private chat, and they're happy to reach out and connect with you as well. So Dr. Smadi, the first question that was presented during your conversation was related to the concept of green endoscopy, which, as we know around the world, is starting to increase. And the question was specifically, in talking about a single-use endoscope, how would you approach individuals who have concerns about green endoscopy and using a single-use endoscope in your practice?
I think that's a great question. So 2 points. Yes, they are single-use, but there is a way to recycle them. So you can contract with a recycling company. EvoEndo will connect you with them if you are interested. So they are not really wasted. There is a way to recycle them. Number 2, remember that sedated EGD are not 100% environmental friendly. Yes, you are reusing the scope, but the material you use to process the scope and to clean the scope are very environmental harmful. So these 2 points to keep in mind. You can reprocess or recycle the scope. You can't reuse it, but there is a way to recycle most of it. And when you use the other alternative, which is sedated EGD, you do create a lot of waste and a lot of things which can hurt the environment as well.
Awesome. Thank you so much. The next question that came in is during your talk, you discussed the risk of anesthesia and the concern that there may be adverse events that are on the rise. The question was related to what literature or evidence would you like to talk about that is related to that discussion point?
I think and if you remember in this slide, in 2016, FDA had a black box warning issued regarding general anesthesia in pediatric patients, and that FDA warning came from reviewing all the literature about doing anesthesia in general, and sedated endoscopy includes general anesthesia almost always. Even if you don't intubate, it's still in general anesthesia. So I understand, yes, sedated EGD usually are short, it's about 15, 20 minutes of under anesthesia, but definitely there is some potential risk of the drugs we use. The younger the patients, the more likely they are harmful to their CNS system. Intubation, IVs, anytime you go in the OR, there is risk of medical errors. So they are not risk-free, and that is why the FDA issued that black box warning in 2016. Again, the length of endoscopy and the length of anesthesia matters. The longer you are under, the more likely it is it's more harmful. So our cases are, yes, short and the risk is low. But if you can do them with no risk at all of anesthesia, you eliminated the whole risk of anesthesia. You still have the risk of bleeding, infection, perforation of endoscopy, but you took off the potential risk of anesthesia, which is supported by the FDA black box warning in 2016.
Awesome. Thank you so much. The next question from one of our participants was, Dr. Smadi, you addressed relating to the reimbursement in the different environments. And as we know, there's outpatient clinic, there's outpatient ambulatory surgery centers, there's facility fees within a hospital environment. And the specific question was related to, was your clinic space where you originally did this in outpatient setting allowed to collect a facility fee? Could this have been the problem with reimbursement in that original space that you were having?
Yeah, definitely. That was exactly the problem. When you do them in a non-procedure place, then it is harder to reimburse for a procedure. So there are some technical, billing points about that, but the facility fee is part of the TNE if you do it in endoscopy suite, for example. But remember that facility fee is still way more less than the facility fee if they go to the OR or to a sedated EGD. Overall, the total cost of EvoEndo and the charges for EvoEndo TNE compared to sedated EGD is significant. We will publish our data once we have enough data about how much do we charge and collect for TNE versus EGDs. But yeah, you have to be careful about, specifically when you start, as I said, the lesson I learned after our first 10 cases, though we obtained prior authorization, we weren't reimbursed correctly, and we could have lost our momentum. Administration could have said, you know what, we tried 10 times, we might have lost money, so no more. So it tries to start with a guaranteed way, and then we still trying to bring it back to an office base. Our colleagues in ENT, they can do laryngoscopy and they can do cases in their endoscopies and they can be reimbursed. I think it's just a journey. The experimental codes, the T codes, eventually I think they will they will work out. That's again, we have to use them to show that they are needed. But if you use them early on, it's a little bit risky. That's our experience. I know, Joe, if you want to add anything, please feel free to add about that too.
No, absolutely. I think that was a great answer. It's, as we know, outpatient space as a outpatient space is just the area that we do it, but how do the different hospitals build that outpatient space? And I think that's a lot of what you were talking about from that perspective. And actually our next question is related to this as well too, Dr. Smadi. The question specifically was, you had mentioned how the new T codes for transnasal EGD were considered experimental. And the question specifically was, if they were experimental, how was EGD getting reimbursed, or how did that work with insurances, A compared to B, and what was your experience with that?
Yes. So if you do a full EGD transnasally and you wanna bill for full EGD, then you have to use one of these experimental codes, which if they reimburse you, it's much better than the traditional codes. So what we did, we built the traditional codes, which did not bill for the full EGD. So we very much built for esophagoscopy or esophagogastroscopy, and we built the same code which we would have built for just an esophagus, intubating the esophagus and the stomach. So that's what that is a real good question. At this point, even when you do a full EGD, if you to my knowledge, if I want to be guaranteed reimbursed, I'm still using the 43197, 43198. I'm not aware of another way to do it without using the experimental codes. But again, I'm not an expert in this field. That's my personal experience.
Awesome. Thank you so much for answering that. Next question, and this is related to a little bit of the training and getting up and running. The question from our participant was, have you found that in-person shadowing of other physicians performing TNE on live patients was helpful when learning the TNE process? And I would sum that same perspective as, what have you found most helpful in that shadowing process, if you did find that helpful?
When I started TNE, I did shadow our colleagues in ENT and the aerodigestive clinic. So how to intube, how do you get to the larynx is a skill you need to learn. The demo is very good. We did not have a demo till we started the EvoEndo process. Before EvoEndo, I just shadowed our colleagues from ENT in the aerodigestive clinic, which I think most people who started TNE program did that step at one point, of their journey. ENT, they do this all the time. And it's the same technique you're going to use to get from the nose to the vocal cord of the upper esophageal sphincter. So that's something we did. Now, I think it's very nice, and it makes it way more easy if you shadow someone who is doing TNE EGD, like someone exactly doing what you expect to do once you start. And I know that EvoEndo do have a system to offer to facilitate that, where they can, if you are building a new EvoEndo system in your practice, they might facilitate you shadowing a well-established center, so you can see cases and see the flow, see exactly what's the rule of everyone, how they are doing it. EvoEndo is not about the skills. You can do this on a demo, but you still need to learn how to deal with a child while you are doing endoscopy awake. So there's a lot of skills you need to learn, how to keep them calm, how to stay confident, how to reassure them, how to allow them to burp, gag, vomit if they need to vomit. So a lot of interpersonal and between you and the patient relationship during these 4 to 6 minutes while you're doing the endoscopy. So I think it's a great idea to shadow someone who's doing them. And I'm very sure, that's one of the reasons why very important to get EvoEndo team involved early on. They can help in facilitating that.
Awesome. Thank you so much. And Dr. Smadi, that actually gets to one of the next questions is after someone is shadowed, let's say, for example, you down in Orlando or another physician around the country, the question was from our participant was any special certification or credentialing required by your institution prior to actually starting and performing it? So once you're ready to go, did you have to do anything?
Not really. There is no, like no one gonna certify you that you are certified transnasal endoscopist. A couple things to keep in mind. You have to be a skilled endoscopist to do this. So, you know, this is not something we propose that pediatricians can learn and start doing in their offices, or allergists, or other people who are involved in the care of children who might need endoscopy. This is for someone who knows how to do endoscopy in the traditional way, and he's skilled to do that. Then he's learning how to do transnasal. Number two, practicing on the demo, the more the better, you know, maybe 50 times, and challenge yourself in time and in certain points, like without touching any of the turbinates, without needing to do aggressive maneuvers with the scope. So keep practicing on the demo. Then shadowing, you know, and seeing someone really doing it in person. Then start your own cases, and you know, your first 5 cases are new to you, but they are not you will see how similar they are to the demo. So yes, this might be your first live patients or live 5 patients, but they are very similar to the demo. And after you do 15, your confidence level goes significantly high. And we were just talking, you know, we probably after you do 30 to 40, you are really confident. So there is no certain number like ERCP or EUS or colonoscopies or endoscopies. This is a new field, and people who are starting this are the pioneers and the people who are going to set the rules. Eventually, probably there will be some rules about like certain numbers. But 5 to 15, you are confident. After 30, you are master. That's my personal opinion.
Thank you so much. And as we're almost done, we have a couple minutes left. I thought one last question that was asked was, you've spoken to me quite a bit about the demand in your region for sedation-free endoscopy is quite high, and there's already a wait list. Would you mind sharing with us what your secret is in presenting it to your practice or presenting it to your patients that demand is generated for our participants that are curious about how to help build up a sedation-free practice once it's started?
I think that's a great question. So it all is about how do you approach families when you present this. So I usually don't tell them, you know, you need endoscopy and there are 2 ways to do this and you choose. You know, we usually say the first thing is you need endoscopy, you know, that is regardless how you do it. Number two, after I say that you need endoscopy, I bring it up. I think you are a great candidate for transnasal endoscopy. Would you like to hear more about it? And if they, you know, I have in the room some brochures about sedation-free endoscopy in each patient room. And if they say, wow, you know, how can you do this? Then I explain a little bit more, and I let them scan a code where they can see some YouTubes of kids having this done. And that, you know, then they are buying in. They are very interested in doing it. So that's number one. You know, it's the way you present it. And I always, for those who are hesitant, you know, I tell them, you know, it doesn't hurt to try. If this doesn't work, you know, what's the big deal? You know, we can definitely do sedated EGD. And if they are very hesitant, I don't go for it. You know, again, this is not for everyone. Some people, if they don't accept even having, you know, some Flonase drops in their nose, they're probably not good candidate for TNE. I am honest and transparent. I tell them you're going to have some discomfort in the nose and in the throat, but the procedure is very short. If we're talking about just the esophagus, it's about 4 to 6 minutes and no IV. So I always bring the IV idea that, you know, here you are not going to have any needle, no poking. We're just going to do the endoscopy, and it's very short. And again, you know, remember that every center did this, have 94 to 98% success rates. Once you convince them that to do it, it's very likely you will be successful finishing it. The second point, the press, because there's a lot of this is going in the community, that people know that there is way to do endoscopy without anesthesia. You will be approached by news, by Facebook groups in your hospital, by different channels to talk about it, and that will increase your referral base. And number three, approach your non-GI folks, the allergist who treat EOE, your speech pathologist who might pick up patients who might need endoscopy, and your own group and the groups around you. So if you approach it this way, believe me, no center started doing TNE and did not have enough volume. That scenario did not happen, and it's not going to happen. If you start it will grow very, very rapidly.
Awesome. Well, thank you so much, Dr. Smadi. It was absolutely fantastic. Thank you for sharing your expertise with us. And that is the end of our webinar this evening. And as I discussed before we started, it'll be an abrupt end, and we apologize for the abrupt end. But as we know, that is how webinars are. So thank you so much for everyone for joining us this evening. And thank you to Dr. Smadi again.
Thank you. Thank you so much. Have a great night.